Total testosterone includes both bound and unbound fractions. About 60% is tightly bound to sex hormone binding globulin, or SHBG, and is not biologically available. Another 38% is loosely bound to albumin and remains bioactive. Only about 2% circulates as free testosterone. When evaluating patients, bioavailable testosterone and free plus albumin bound best reflects functional androgen status, which becomes even more clinically important in conditions that alter SHBG, or sex hormone binding globulin. So if we look at kind of this breakdown, we can see the breakdown between sex hormone bound, albumin bound, and free testosterone, really displaying those percentages. Again, our sex hormone binding globulin levels can drastically alter total testosterone results. Conditions that increase sex hormone binding globulin, things like aging, hyperthyroidism, cirrhosis, HIV, or even estrogen therapy can make total testosterone appear falsely normal despite low bioavailable levels. In contrast, obesity, hypothyroidism, diabetes, and glucocorticoids use reduce sex hormone binding globulin, which can mask low production by artificially elevating the free fraction. So lots of things can potentially be interfering factors here. When we test testosterone, when we're screening for things like hypogonadism or testosterone deficiency, the first testosterone level can be drawn anytime, but confirmation must be done with a morning sample because of our circadian peaks. After age 50, total testosterone becomes less reliable due to rising SHBG. Therefore, free testosterone is the most accurate assessment, but requires an equilibrium dialysis, which not all labs will offer. Many clinicians use calculated free testosterone based off of total T, SHBG, and albumin. Here are some standard ranges in our AMAB individuals as well as our AFAB individuals. AFAB individuals still have testosterone, but they have a physiologic lower level. In our AFAB patients, monitoring elevations may suggest PCOS, polycystic ovarian syndrome, while levels above 200 raise concern for androgen secreting tumors. So that's kind of like our goals. If it's over 200, we need to rule out an ovarian tumor. Understanding these cutoffs can help guide diagnostic reasoning for hyperandrogenism, for instance. Looking here, we can see what are some causes of low versus high testosterone levels. Low T can result from primary testicular dysfunction like Klinefelter syndrome, or secondary causes like liver disease, or even treatments for prostate cancer. High testosterone in an AMAB individual raises suspicion for testicular or adrenal tumors, or even precocious puberty in younger individuals. In AFAB individuals, markedly elevated testosterone suggests PCOS, or ovarian tumors, or even adrenal pathology. You always want to evaluate the clinical context alongside your lab findings. You also want to ask your patient if they are taking any testosterone, either topically or injectables, to ensure that you're appropriately measuring their levels compared to what they are potentially exogenously taking. When we are looking to investigate in testosterone abnormalities, timing does matter. So collecting labs at 8 a.m. Could be helpful because our sex hormone binding globulin levels can either increase or decrease depending on our metabolic, endocrine, underlying conditions, which impacts then our interpretation of total versus free testosterone. If SHBG is altered, calculating free or bioavailable testosterone becomes essential to avoid a misdiagnosis. You want to consider reversible causes like obesity, medications, thyroid status, and liver disease before labeling a patient as hypogonadal or having a testosterone deficiency. Speaking of hypogonadism, primary hypogonadism refers to testicular failure, meaning the testes cannot respond appropriately to LH and FSH. Because testosterone production is failing, the normal negative feedback on the pituitary is lost. So FSH and LH levels will be elevated. Klinefelter syndrome is the most common cause and is characterized by seminiferous tubule dysgenesis and a 47XXY karyotype. Clinically, these patients may present with small testes, infertility, gynecomastia, and low testosterone. Secondary hypogonadism originates from the hypothalamic or pituitary dysfunction. In this case, FSH and LH are either low or inappropriately normal, leading to low testosterone despite functioning testes. This can be caused by a systemic illness, pituitary disease, chronic stress, caloric deficiencies, or even medications. And some conditions like mixed hypogonadism have features of both primary and secondary. So in our AMAB individuals, if we're looking at primary hypogonadism, the testosterone's low and the gonadotropins are high. In secondary hypogonadism, both testosterone and gonadotropins are low. In some cases, testosterone may be normal, but symptoms persist. So further evaluation of free testosterone or SHBG might be necessary. And these patterns will guide your next diagnostic steps as well as imaging determinations. And this is looking at an example algorithm. There's many of these out here. This kind of walks you through your clinical workup, first getting a morning testosterone level, total testosterone level. If low, repeat using free or bioavailable testosterone if SHBG abnormalities are suspected. Next, evaluate LH and FSH to differentiate primary versus secondary, and always exclude any reversible causes like illness, medications, nutritional deficits, or even substance use. If secondary hypogonadism is suspected, consider a pituitary evaluation, prolactin levels, iron studies, and even an MRI if indicated. This is another example of evaluating hypogonadism in an EMAB individual. Again, there's lots of these that kind of give you a list of steps to follow. Now, testosterone regulation in AFAB individuals, it's still important to pay attention to testosterone levels in our AFAB individuals because although AFAB individuals categorically produce much less testosterone, it still plays key physiologic roles. About 60% of AFAB testosterone comes from peripheral conversion of precursors like androstenedione and DHEA, with only really small contributions from the ovaries or adrenal glands. Therefore, understanding this balance is really essential when addressing hyperandrogenism because enzyme activity or adrenal dysfunction can significantly alter serum androgen levels. If there's elevated testosterone in an AFAB individual, it's most commonly associated with PCOS, but there can be other diagnoses. Adrenal or ovarian androgen secreting tumors, as well as conditions like Cushing's syndrome, must also be considered. When elevations are significant, virilization can occur, including deepening of the voice, increased muscle mass, changes in hair pattern growth. Therefore, testosterone levels often correlate with the degree of virilization, which can help guide urgency of evaluation. I mentioned, let me see if I want to keep going through. Yeah, we'll finish up this section. So PCOS or polycystic ovarian syndrome is the most common cause of chronic anovulation and hyperandrogenism, especially obviously in our AFAB individuals. These patients typically show an elevated LH to FSH ratio and significant insulin resistance. This also then therefore amplifies our androgen production. Long-term risks can include infertility, metabolic syndrome, type 2 diabetes, dyslipidemias, endometrial hyperplasia, or even cancer. Therefore, recognizing PCOS early on allows for interventions that can reduce these long-term complications. Diagnosis is based off of the Rotterdam criteria, and it requires two of the following three: oliguria or anovulation, clinical or biochemical hyperandrogenism. This could be a lab test, but it doesn't have to be. It could just be signs clinically of excessive androgens, some of those symptoms that we mentioned earlier and or polycystic ovaries on ultrasound, often described as a string of pearls, but not always. Testosterone levels are often elevated in about 70% of patients, but not everyone. That's why they're not required for diagnosis. LH and FSH here are poor diagnostic markers, although they could kind of give you some clinical context. But you always want to rule out other causes of androgen excess, such as late congenital adrenal hyperplasia or even an adrenal tumor. So this slide kind of gives you an idea of what a diagnostic pathway for androgen excess could look like when a patient who's amenorrheic, not having periods or cycles. Initial labs can include a testosterone, a DHEAS, FSH, and LH. And then based off of the values and the findings here, it kind of directs you to where you go. If DHES or DHEAS is elevated, especially markedly elevated, greater than 700, adrenal tumor is suspected. And so you'd want to rule out that first. Testosterone's above 200 suggests an ovarian tumor. If 17 hydroxyprogesterone is elevated, consider late onset congenital adrenal hyperplasia. And lower elevations in testosterone typically point more towards PCOS diagnosis. When we come back, we're going to talk about prostate cancer and the benefits versus drawbacks of a PSA.